Hi, my name is Richard Savell. I'm the Director of Surgical Critical Care here at Maimonides Medical Center in Brooklyn, New York, and I'm also a Professor of Clinical Medicine and Neurology at the Albert Einstein College of Medicine. The focus of this particular presentation is to go over some of the important recent clinical trials that have been performed in the last year and a half, focusing in on the important question of what is the best evidence-based approach to the early resuscitation of patients with severe sepsis and septic shock. The three trials that I'm going to be focusing in on are the PROCESS trial, the ARISE trial, and the PROMISE trial, with a focus on reevaluating what the standards of practice should be. This is a talk focused in primarily for a house officer on their ICU rotation. First, some definitions. As many of you know already, infection and 2 or more SIRS criteria are considered sepsis, and as you can see here, temperature, respiratory rate, heart rate, elevated white count, or evidence of decreased PCO2. Here you can see severe sepsis is sepsis with evidence of organ dysfunction or hyperlactatemia, and septic shock is severe sepsis syndrome where the patient remains vasopressor dependent despite adequate and appropriate volume resuscitation. Just some other slides visualizing similar information. Here's a nice important famous Venn diagram focusing in on the overlap of infection, SIRS, sepsis, severe sepsis, and septic shock. And as you can see here, other disease entities where there is SIRS without necessarily having an infection. So this all relates back to this important landmark trial published in November 2001 in the New England Journal of Medicine, Early Goal-Directed Therapy in the Treatment of Severe Sepsis and Septic Shock, published in the New England Journal of Medicine by Rivers et al. And again, what they did, and it's very important to go over it, was looked at patients, and a total of 263 patients, and randomized patients who met criteria for septic shock, and randomized them either to standard therapy in their emergency department or early goal-directed therapy. And what's interesting and important is that their standard of care was reasonable in terms of targeting a CVP, mean arterial pressure, and urine output, and the differences in the early goal-directed therapy measuring central venous oxygen saturation and other components that we'll be discussing in the next slide. So again, here's the world-famous chart here from the Rivers study where you take a patient and you fill up the tank targeting a CVP appropriately with either crystalloid or colloid, and then targeting a mean arterial pressure of greater than or equal to 65 millimeters of mercury with vasoactive agents. And then importantly, interestingly, looking at SCVO2, central venous oxygen saturation, as a marker of global oxygen delivery. And if that number was not high enough, here you can see if it was less than 70% to transfuse blood to keep the hematocrit greater than 30%, and if it was still low, to use inotropes. And the fundamental question of these other studies was, is this necessary, or is this necessarily the best way to manage patients early on with sepsis? Or I guess the best way to say it is it mandatory if you're taking a patient with severe sepsis syndrome that you use this particular protocol? And again, just to read the protocol to you, you can see beginning with a 500 milliliter bolus of crystalloid given every 30 minutes. If the mean arterial pressure was less than 65, starting vasopressors, currently norepinephrine used as the primary vasopressor. If the central venous saturation was less than 70%, giving red cells. And if the central venous pressure, mean arterial pressure, and hematocrit were optimized if the central venous oxygen saturation was still less than 70%, to begin an inotrope, specifically dobutamine. And again, this is just showing this important graphic again that has become an international standard of care for resuscitation. And again, these are some of the results showing that by taking patients and randomizing them to early goal-directed therapy, and again, only approximately 130 patients in each group, the in-hospital mortality was decreased from 46.5% down to around 30.5%. You can see that the 28-day and 60-day mortality were also decreased. And this is just representing that data again, showing the number needed to treat for both in-hospital and 60-day mortality. You can also see the total amount of fluids given, 0 to 6 hours, where the focus is 4.9 or approximately 5 liters compared with 3.5 liters. You can see the 0 to 72 hour significant amount of fluid given. You can also see that there was much less red blood cell transfusion given in the standard therapy group. And again, inotropes much less in the standard therapy group. So as I mentioned before, this has become a de facto standard of care for the last 14 years for how to resuscitate a patient, and has led to important bundles of care. And there is a 3-hour and a 6-hour bundle. This has been integrated into the Surviving Sepsis campaign, now printed with numerous revisions. And again, the 3-hour bundle, measuring a lactate level, obtain blood cultures prior to administration of antibiotics, administer broad-spectrum antibiotics, and begin with administration of a 30 milliliter per kilogram crystalloid bolus for hypotension or hyperlactatemia. Within 6 hours, as you can see here, to apply vasopressors to keep the mean arterial pressure greater than or equal to 65 millimeters of mercury, and in the event of persistent arterial hypotension despite volume resuscitation, or if there is hyperlactatemia, to measure a CVP or measure a central venous oxygen saturation and remeasure lactate if the initial lactate was elevated. And again, the reason I want to focus on this is that there is new data, there are new things to think about, and that's the focus of this talk. So the 2015 update, following up on these initial studies published in the early 2000s, are to challenge the status quo. And the focus here is to look to determine if there really is any benefit to using the approach of early goal-directed therapy versus usual care in patients with septic shock. And you can see the little fish jumping out, challenging the status quo. So the 3 studies that we're focusing in on, in which there was a total of 4,200 patients combined, are the PROCESS trial, published in the United States in March of 2014, the ARISE trial, published in Australia and New Zealand in October of 2014, and the PROMISE trial, published in England in March of this year, 2015. So the PROCESS, ARISE, and PROMISE trials really are world-class trials in critical care medicine, so they're highly worthy of discussion. So let's begin focusing in on round 1 of early goal-directed therapy versus usual care. This was, as I mentioned previously, published in the New England Journal of Medicine in May of 2014, a randomized trial of protocol-based care for early septic shock. So the PROCESS trial was performed in 31 emergency departments across the United States, and patients, and this was a 3-arm trial, with septic shock to one of 3 arms: protocol-based early goal-directed therapy, protocol-based standard therapy that did not require the placement of a central venous pressure, triple lumen catheter, inotropes, or blood transfusions, and then usual care. The primary endpoint was 60-day mortality, and in this study they tested sequentially whether protocol-based care was superior to usual care, and then whether protocol-based early goal-directed therapy was superior to protocol-based standard therapy. They enrolled approximately 1,300 patients, which for any of you who've been involved in critical care research, this is a monumental process in itself, and you can see here the number involved in each of the three arms. So first step was looking at 60-day mortality. You can see in the early goal-directed therapy group, it was around 21%. In the protocol-based standard of care, it was 18%. And in the usual care arm, it was 19%, and these were not statistically different from each other. Then sequentially, the relative risk of death was not different amongst the groups, protocol versus usual care, and early goal-directed therapy versus protocolized standard care. Again, this was just for completeness to show you that in the trial, the early goal-directed therapy protocol was identical to the protocol utilized in the original trial. I wanted to spend a few moments focusing in on what they considered as this other protocol that didn't require some of the components that were utilized in the early goal-directed therapy trial. You can see here they began with a fluid bolus of between 500 and a liter, 500 milliliters and 1,000 milliliters. They then measured the shock index, which as you can see here is the heart rate divided by the systolic blood pressure, and if that value was greater than or equal to 0.8, it was suggestive of shock. And then the question was, if it was concerning for shock, was the patient fluid replete or not? And if they were, then you would start pressors, and if you would not, you would bolus the patient again. And here you can see their monitoring protocol. This is the 60-day mortality here. You can see again 21%, 18%, and 19%. The 90-day mortality, 32, 31, and 34% respectively, without statistical difference. The admission to the ICU, there was a significant p-value showing that the early goal-directed therapy group was slightly more likely to be admitted to the intensive care unit. And there's some theoretical issues there that it may have been that you were taking patients and because of the protocolization, you were turning them into ICU patients when they may not have otherwise required ICU admission. Again, this is the Kaplan-Meier survival curve showing no differences either to 60-day mortality or cumulative 1-year mortality. In terms of resuscitation, during the first 6 hours, the volume of intravenous fluids given was different amongst the three groups. And here's some of that data. As you can see, the early goal-directed therapy group received approximately in the first 6 hours 2.8 liters versus 3.3 liters in the protocol-based standard care and 2.3 liters in the usual care arm. And I think the important issues here are that giving fluid matters, but the precise amount may not matter so much. So here are some of their conclusions of the process trial. In our multi-center randomized trial, in which patients were identified early in the emergency department as having septic shock and received antibiotics and other non-resuscitation aspects of care promptly, we found no significant advantage with respect to mortality or morbidity of protocol-based resuscitation over bedside care provided according to the treating physician's judgment. That's a big deal. We also found no significant benefit of the mandated use of central venous catheterization and central hemodynamic monitoring in all patients. So now, on to the second trial. The ARISE trial. Goal-directed resuscitation for patients with early septic shock. This was published by as you can see here, the Australasian Resuscitation in Sepsis Evaluation, or the ARISE study. So they looked at 1,600 patients at 51 centers, mostly Australia or New Zealand, with early septic shock to receive either early goal-directed therapy, approximately 800 patients, and usual care, another 800 patients, with the primary outcome being 90-day mortality again. So let's start with looking at the mortality, somewhat lower, 18.6% versus 18.8%, but clearly not statistically different from each other, clearly no obvious benefit to the use of early goal-directed therapy. This is the volume of fluid given in the first 6 hours, more fluid given in the early goal-directed therapy arm compared with the usual care arm, and this was statistically significant. One of the other questions they asked was how likely were you to receive pressors, blood, or dobutamine in this trial? And the blue is early goal-directed therapy and the red is usual care. You can see that if you received early goal-directed therapy, you were more likely to receive pressors, blood, and an inotrope. You were also more likely to receive vasopressor support. The amount of, or the percentage of patients receiving invasive mechanical ventilation wasn't different between the two arms, and it wasn't very high either. That's a very important point. And again, this is another Kaplan-Meier survival curve showing that they were not different from each other. And here's a subgroup analysis showing no real particular subgroup in which early goal-directed therapy appeared to improve things. So their conclusions were that in this randomized trial, they found that early goal-directed therapy, as compared with usual care, did not reduce 90-day all-cause mortality among patients with early septic shock. Also, there was no significant differences in 28-day or in-hospital mortality, duration of organ support, or length of hospital stay. And in terms of the most recent trial, the PROMISE trial, this was published in England in March of 2015 in the New England Journal of Medicine. Protocolized management in sepsis. This was a pragmatic randomized trial in 56 hospitals in England, and patients with early septic shock were randomized to receive either 6 hours of early goal-directed therapy or 6 hours of usual care. Again, the focus was 90-day mortality. You can see here the number of patients involved. Here we begin by looking at the 90-day mortality in the two groups, and they were nearly identical. And the early goal-directed therapy group had an increased use of IV fluids, vasoactive drugs, and red cell transfusions. The early goal-directed therapy group had worse organ failure scores, more days receiving advanced cardiovascular support, and longer stays in the ICU, with no between-group differences in any other secondary outcomes. In addition, this trial had a cost-effectiveness analysis, and I'd like to talk about that for a few minutes. The evidence was that early goal-directed therapy increased costs, and the probability that it was cost-effective was below 20%. You can see here that the PROMISE trial baseline in terms of having refractory hypotension was quite similar in the two groups. Having an elevated lactate was similar in the two groups. The amount of fluid that the patients received prior to randomization was approximately 2 liters, and this was important because it was similar amongst all of these trials, and it's important to keep that in mind when you're trying to relate this to clinical practice. You can see here the source of infection was primarily lung, the blue being, again, early goal-directed therapy, and the red being usual care. And again, the overwhelming majority being lung and urine. This was not primarily a surgical trial. You can see here that when you compare the usual care versus early goal-directed therapy, that you were much more likely to receive a central line if you were randomized to early goal-directed therapy, which again, although it is practiced with much safety these days, if you can avoid it, it's better for the patient. And again, you can see the total 0 to 6 hour fluid, again, another 2 liters or so. Just another slide showing that if you received early goal-directed therapy, you were much more likely to receive blood without any obvious benefit. And one of the important points that's brought up here was that although it wasn't much different, it was statistically different, that your SOFA score as a marker of organ failure was higher in the early goal-directed therapy group. And one of the reasons was that you were more likely to be on pressors if you received early goal-directed therapy. And that's one of the markers in the SOFA score to give you an elevated marker of organ dysfunction. You were also more likely to receive what's called advanced cardiovascular support in the early goal-directed therapy group. And your median length of stay was statistically, but clinically questionably higher in the early goal-directed therapy group. And just again, for completeness sake, the definition of advanced cardiovascular support was, as you can see here, receipt of multiple IV and or rhythm controlling drugs, observation of cardiac output, intra-aortic balloon pump, or a pacemaker. And again, here's a description of the SOFA score showing the different organ systems: respiratory, renal, hepatic, cardiovascular, hematologic, etc. And each gets a particular score ranging from 0 to 24, with the higher numbers being worse. This was the interesting data from cost effectiveness, again comparing early goal-directed therapy with usual care, and they calculated what are called health-related quality of life on this EQ5D, which is a score where you ask people how they're feeling, rating them from 0 to 1, where the higher number is more concerning, and you can see they were not statistically different from each other. And you can see there was no obvious cost savings. Here's the Kaplan-Meier curve again. And so here are some of the conclusions of the PROMISE trial. In our study involving adults with early signs of septic shock who presented to the emergency department in England, there was no significant difference in mortality at 90 days among those receiving 6 hours of early goal-directed therapy and those receiving usual resuscitation. More patients receiving early goal-directed therapy were admitted to and spent more days in the intensive care unit. Treatment intensity was greater in the early goal-directed therapy group, driven by adherence to the protocol and indicated by the increased use of central venous catheters, intravenous fluids, vasoactive drugs, and red cell transfusions. On average, the use of early goal-directed therapy increased costs, and given similar qualities in the two groups, the probability that early goal-directed therapy was cost-effective was below 20%. In conclusion, the studies here suggest that techniques used in usual resuscitation have evolved over the 15 years since the landmark study by Rivers et al. The addition of continuous central venous oxygen saturation monitoring and strict protocolization did not improve outcomes. Our results complete the planned trio of studies of early goal-directed therapy, all of which showed that early goal-directed therapy was not superior to usual care. So in terms of a preliminary comparison of all three trials, you can see that the 90-day mortality was lower in the ARISE trial, and the idea there is a thought that they were patients that were not as sick, that the Apache 2 scores were lower in the ARISE trial, but not by much. You can see here, importantly, that the amount of fluid given before randomization was somewhat comparable, somewhere between 2 and 3 liters, and that the total fluid given in the 0 to 6 hours ranged between 1.7 and 2.2 liters. If you compare the three trials in terms of what percentage of patients had either refractory hypotension, elevated lactate, or both, you can see that the PROCESS trial and the PROMISE trial had a similar proportion, although the ARISE trial had an increased proportion of patients with refractory hypotension. I believe this is thought-provoking. I believe this is hypothesis-generating, but it's unclear precisely what this means and if this really explains the differences in mortality amongst the trials. I think it's important to note that these trials have been designed with each other in mind, so that as meta-analyses start coming out, it's important to know that, so that this data really can be used to try and generate important meta-analyses and important outcomes. So in conclusion, I hope you've enjoyed hearing about some of this important recent research, which appears to show that early recognition of sepsis matters and that early provision of fluid and antibiotics matters, but what's less clear is a mandate for a particular protocol and a mandate for continuous venous oxygen saturation measurement. There will be much discussion and further publications regarding these important studies. Stay tuned. Thank you so much.